Hi everybody, this is Professor Staub. This is Chapter 1 in Abnormal Psychology, Understanding Psychopathology. The first thing we want to do is define what constitutes a psychological disorder. So I want to define that for you. A psychological disorder is psychological dysfunction that causes stress or impairment in functioning that results in atypical behavior. So let's break that down a little bit. Right. We all have stress or so forth, but when our abnormal behavior causes impairment, when it limits your life, that's when we start defining psychological disorders. A psychological dysfunction is a breakdown in cognitive, emotional, or behavioral functioning. This begs the question, what is abnormal? This is a very controversial question, despite the fact that it's pretty simplistic. It's open to a lot of interpretation. The formal definition of what is abnormal is simply deviating from social norms versus what is a serious problem. So abnormal is deviating from the norms. Okay, that doesn't necessarily mean that abnormal is a problem. It's only a problem when it becomes dysfunctional to your life, when you can't engage in normal activities like going to work, engaging in relationships, etc. That's when abnormal becomes a problem. Distress is something we all experience from time to time, and that's normal. But if distress occurs when it shouldn't, or if it occurs with excessive frequency, this becomes problematic as a result of specific behaviors. Impairment keeps you from normal engagement and function. So experiencing distress, experiencing impairment as a result of abnormal behavior is the problem where disorders are concerned. If you engage in abnormal behavior and you don't experience distress and there's no impairment or dysfunction in your life, well, okay, then it's not a problem. Psychopathology is the scientific study of psychological disorders conducted by psychologists, psychiatrists, and social workers. I want to make the distinction between what each one is because they all have different educational backgrounds, and they do a little bit of, based on those backgrounds, their focus is a little bit different on how they treat somebody with a disorder. So first, a psychologist is somebody with a PhD. There are all kinds of psychologists with PhD, but for the specific purposes of abnormal psychology, we focus on psychologists who have concentrated their study in mental illness. Specifically, they're looking for causes and treatments. They do a lot of research into causes and treatments, and they also engage with clients in one-on-one counseling or group counseling therapy. Psychiatrists, on the other hand, do not have a PhD. They have an actual medical degree. They specialize in that medical degree in psychiatry, and they treat clients with mental illness with a specific focus on biological causes and drug treatments, in addition to psychosocial therapies. So basically, psychiatrists are looking at hormonal imbalances, brain dysfunction, etc. What's causing it, what's causing the physical problems that are manifesting themselves in behavioral abnormalities. Then they seek to find a drug that can control those behavioral or those biological dysfunctions in order to get the behavior under control. However, they don't leave therapy behind. They still engage with therapy with their patients. Finally, a social worker is somebody who has a master's degree in social work. And these are individuals who will collect social and familial information on the individuals suffering from a disorder. The reason they do this is they are trying to determine is the distress that you're experiencing caused by environmental factors, stress with family, stress with work, or is it something else? Is it something internal? They collect this historical information in order to get a context for what the problem is with the individual. Again, they can also apply treatment focused on familial issues. They can treat people individually with therapy, or they can treat people in groups. What they all do, psychologists, psychiatrists, and social workers, are all looking to create a clinical description. And a clinical description is the combination of behaviors, thoughts, and feelings that make up a specific disorder. In addition, they have to be familiar with other issues of mental illness, such as prevalence and incidence. So let me define them, and then I'll explain why they need to know this. Prevalence is the number of people in the population that have a given disorder. Incidence is how many cases of a disorder occurred in a given time period. When we determine incidence, we typically look at 12 calendar months, a full calendar year. It's important to have understanding of prevalence and incidence because it gives contextual information and background for those looking to diagnose. How common is this mental illness? How rare is this mental illness? Did it increase? Did the incidence increase in our population in the past year, or did it decrease? If so, why? what's driving that. It just provides contextual background that they can make better decision making off of. Finally, or in addition, there are 4 different onsets of mental illness that I want you to know the distinction of. The first is chronic mental illness, and this is mental illness that can last a very long time. It's typically chronic mental illness is something somebody will suffer from their entire life. It doesn't mean that they can't have success with treatment. They can. They may or may not. But it's something that will be a lifelong issue. It will not go away, right? Versus episodic, which is mental illness that can typically be treated successfully over a short period of time. So somebody can get treatment, they can go into remission, so to speak, with the illness, but it has a possibility of reoccurring later in life. Episodic mental illness tends to be triggered by high stress times in an individual's life. So if you go through a period of time that's low stress, you may not experience symptomology from the illness for many years, many months, many years, but it still could come back at some point, especially when you're experiencing high rates of stress. Next is acute onset, and this is when a disorder begins suddenly and without any warning. There's no buildup, there's no signs, it just one day you're fine and boom, one day you're not. That's acute onset. Finally, there's insidious onset, and this is when a disorder begins to develop symptoms gradually over a period of time until it becomes very obvious that the individual is suffering from a disorder. So the symptomology may start out very slow, few and far in between, but over time it will gain momentum. You'll see more and more of the symptoms, and then it will become very apparent that the individual has a disorder. Knowing whether the illness is chronic, episodic, acute, or insidious allows practitioners to make a more informed prognosis on the treatment and the outcome of the disorder. So knowing how the mental illness is going to behave over time allows them to make decisions about what therapies to use, what drug therapies to use, and what we can expect down the road for that individual. Finally, I want you to know the medical terminology of etiology, which is, again, like I said, it's medical terminology. It's the origin or cause of a disease or disorder. And here in this focus of abnormal psychology, we want to know the causes of disorder. If we know the causes, it can help us with treatment. It can also help us with prevention. It's better to prevent than to treat. Okay, I want to get into historical perspectives on mental illness and abnormal behavior. This is just a brief history of the way humanity has reacted to abnormal behavior over time. It's important for us to understand the development of therapy and understanding of abnormal behavior over time because it gives us context with which to see how far we've come, how many improvements we've made, and where we still need to go with it. So for many, many hundreds of years, we subscribed to the supernatural model. So long before we had the scientific method and more advanced understanding of everything, right? People were just more simplistic. When there was abnormal behavior or mental illness, it was frequently defined as or explained by you have demons, you have spirits inhibiting you, you're engaging in witchcraft, and common methods of treatment were exorcisms, which were performed by religious bodies in order to try and extract the evil being from the individual to stop the bad behavior or the abnormal behavior. Obviously, this was inaccurate and it did not work, right? But time passed and we progressed in terms of understanding and technology, and the biological tradition was born. Specifically, this was presented by Hippocrates, who suggested that mental disorders can be treated just like any other physical ailment or disease. He argued that mental illness was caused by brain dysfunction or brain damage in addition to other biological etiologies. He was well ahead of his time. We still subscribe to this very basic concept of the biological tradition. It didn't catch on for a long time, right? It took some time. But this is something that we still anchor our explanations to in terms of what causes disorders and how to approach them. Finally, we have Galen, who believed that mental illness was a result of the humors being out of balance. Humors, H-U-M-O-R-S, was a concept, again, long before we had medical understanding and technological understanding. We thought that people had humors, which were 4 different fluids in the body. And when the fluid was out of whack, meaning when there was too much of one or not enough of another, they argued that that's when we saw abnormal behavior. Specifically, the humors were defined as blood, black bile, yellow bile, and phlegm. Approaches for treatment would say, for example, you have too much of one, we need to get you stabilized. So you have too much blood, let's cut you and bleed you, get rid of some of the excess blood, and we'll get back to homeostasis. Obviously, again, this was not accurate. It was not successful. Other treatments to restore the humors would be increasing or decreasing heat or cold, dryness, moisture, inducing vomiting to get some of that bile out, but it really didn't do anything to treat the mental illness. So we were way off there for a really long time. Then we had a breakthrough with syphilis, which is maybe the only time in your life you'll ever hear that sentence. Syphilis is a sexually transmitted disease that's a physical illness. Causes behavioral and cognitive dysfunction as the disease progresses to later stages. It also causes serious physical deterioration as well. But in the later stages, it causes delusions, hallucinations, paranoia. Eventually, the deterioration physically and mentally results in death. And what we see is the cause of death is deterioration of the brain, which is what's causing the behavioral abnormalities. However, we made a breakthrough because we found that people who suffer or were suffering from syphilis who contracted malaria, a very serious physical ailment, would oftentimes survive. We'd see the syphilis go away. We'd see the impact of syphilis go away. And the theory was that malaria cured syphilis because it came with very, very high fevers, and it would burn out the syphilis, right? Thus, a new idea in treating mental illness was born. The concept that mental disorders were cured through treatments similar to the way in which we cure physical ailments became the prominent thought process in terms of how we approach treating mental illness. This provoked further biological approaches that were developed and expanded, and they've been evolving since they've been developed over time. We started out pretty rough. We have advanced. We are still working on it. This began with early medical treatments like administering extra insulin into people, which we now know is a very dangerous thing to do. It doesn't heal mental illness, and it doesn't do anything good for the body. We made wide use of electric shock therapy in the past. We still use it, but we use it much more judiciously now, much more sparingly than we used to. We just sort of use it on everybody at one point, and we've dialed that back. This led to the discovery of sedatives and anti-anxieties in order to calm delusions and paranoia. We still use sedatives and anti-anxieties. Again, we use them differently. We are more specific in their application. Once upon a time, everybody was just administered high rates of sedatives and anti-anxieties, which sort of had a zombie effect on them, which made them easier to control and maintain. It's also inhumane to do that. So we want to be more judicious, and we are more judicious with them, prescribing and applying when necessary and controlling dosage, right? Okay, so from there we went on to the psychological tradition. And with the psychological tradition came the birth of psychosocial treatment, which you probably know more commonly as therapy or psychotherapy, talking with a therapist. Psychosocial treatment focuses on psychological causes in addition to social and cultural causes of mental illness. This was a really big step in terms of the history of how we handle mental illness because it led to the reform and the decline of the asylum system. Prior to this, we made widespread use of asylums, and asylums were pretty terrible, right? It was basic maintenance. Basically, somebody with a mental illness, we throw them in there. Frequently, use of restraints was a part of maintaining them from acting out, hurting themselves, hurting others, and we would just send them there, and they'd stay there till they died. And for many people, they stayed there many, many decades, right? And it was a horrible existence. But with the introduction of psychoanalysis, we said, let's get them out of there, let's stop chaining them up, and let's talk to them and see if we can figure out what the problem is, which, believe it or not, was revolutionary at the time. This was introduced by Sigmund Freud, which is why we still study him today. He revolutionized the way we handle the mentally ill. So Freud said we need to talk to them. We need to look at development, growth, the structure of the personality, look at everything in totality and see where the problem lies. See if we can identify the problem and then work it out rather than just locking everybody up. He also introduced the idea of catharsis, which is the desired outcome of the psychoanalytic model. Catharsis is the release of emotional tension as a result of psychotherapy. We talk it out, we figure out what the problem is, and then we find a way for you to obtain catharsis, a way to expel that tension, that emotional upset, so that you can feel better and move on, right? This is why we still study Freud. Freud's theory, if you want to go get Freudian therapy, you can absolutely go find it. You can pay for it. It's not effective. It doesn't hold up statistically. But this is why we still study him, because he's the one who introduced this concept. He revolutionized the way we handle the mentally ill. He argued that there was 3 specific structures to the mind: the id, the ego, and the superego. He argued that the id was the source of all of our sexual and aggressive tendencies, and that it always functions according to the pleasure principle, meaning I'm always looking to maximize my pleasure, my benefits, and minimize discomfort and unpleasantness. The id functions in a very selfish capacity. The ego operates according to the reality principle, which ensures that we behave realistically and appropriately. And the superego is just a fancy word, according to Freud, for our conscience, right? The voice within us that tells us what's right, what's wrong, what we should be doing, what we shouldn't be doing. According to Freud, these 3 are at work at all times, and they're always fighting each other for balance. When there's too much of one, right, too much of the id, or the id has too much control, we'll see behavioral issues. And we have to find a way to get them back in balance. Other approaches were also born in psychology that have differing perspectives and differing treatment approaches, such as behaviorism, the concept that behaviors, good and bad, are learned and therefore can be unlearned. Classical and operant conditioning are explanations for healthy and abnormal behaviors. And humanism, which focuses on personal needs being achieved or denied. All of these approaches dictate how treatment occurs. And that is the end of chapter 1.